All right. Good afternoon. My name is Tyler Logan. I am a project coordinator for the Center for Behavioral Health and Justice. I will say good afternoon to those of you who are with us for Eastern Standard Time. And if you're in the evening space or in the morning space, good evening and good morning to you all. Today's event is titled COVID-19 Communications, Preparedness, and Mitigation, addressing the infodemic and the pandemic. And just as a brief point of clarification, an infodemic is not a new term, but has been used more in today, especially in light of the frequent information sharing related to the COVID-19 pandemic. An infodemic is the rapid and far-reaching spread of both accurate and inaccurate information about something, such as COVID-19 vaccines, for example. Next slide, Stacy. Again, welcome to all of you who are joining us today, whether this is your first Community of Practice webinar with us or you've been along this journey with us since December. We appreciate you for taking your time out of the day to join us. Next slide. We have a full agenda today. We'll review Zoom housekeeping per usual, and we'll then move into the presenters for this month. Dr. Nancy Rhodes will lead us in her presentation titled, Let's Talk About It, Health Communication Strategy for Justice-Involved People. Following this, Bianca Birch will walk us through culturally responsive education and communication for vulnerable populations. And then wrapping up our presentations, we'll hear from Parsa Irfani, highlighting how their team has used similar strategies in multiple jails during his presentation titled COVID-19 Vaccine Education in Carceral Settings, an interdisciplinary model. And then lastly, we'll end with our panel discussion and next steps. Next slide, Stacy. Thank you. Again, these slides will be made available to you all after today's presentation. The session is being recorded and again will be publicly made available not only in the follow-up email, but also on our webpage. And then just to remind you all, and if this is your first time with us, the Q&A chat box feature is available. So at the bottom of your screens, you should see a Q&A tab. You can post and add any questions to that tab throughout the presentation, and we'll make sure that we either answer them along the way, or of course, try to answer them during the facilitated dialogue that we'll have later on today. Next slide, please. And with that, I will hand it over to Dr. Rhodes for her presentation titled, Let's Talk About It, Health Communication Strategy for Justice-Involved People. Thank you.
Hi, everyone. Thanks, Tyler, for that introduction. So I'm here to talk about, obviously, health communication. Next slide, please. I wanted to present a general model of communication to help us understand and to focus our conversation today. And this is a very simplified idea of what happens when communication is happening. But in the general case, we have a sender who creates a message and transmits it through a channel to a receiver who then has to interpret and understand it. Now that receiver can give feedback to the sender, which helps the sender know if the communication has been received well. All of this takes place in the context of this gray oval, which represents noise. Now, noise can be physical noise in the environment. You know that it's hard to have a conversation at a rock concert, for example, but noise can also be psychological noise, and these would be psychological things that are getting in the way of good communication for both the sender and the receiver. So let's see some of the barriers to communication. Next slide, please. So barriers to communication can occur at any of the steps along the way. The sender, and one of the things that I wanted to say is that in the general case that we're going to talk about today, I'm thinking about somebody from the jail as the sender talking to a detainee about the need for a COVID vaccine. And that's the general case that we'll be talking about. But I want to also emphasize that the sender and receiver, those roles switch in the course of a conversation. And also the receiver in the context of communication around COVID in jails, the receiver could be jail staff who are getting information perhaps from the CDC or from state health departments and so forth. So these roles are varied, and we're talking about only a small slice of what happens in the communication context. So the barriers to communication at the sender side could be these things that keep you busy, workload, time pressure, but also there's a power differential by definition between somebody from the jail talking to a detainee, and that power differential can also get in the way of communication. The receiver, in this case, somebody who is perhaps new to the jail system, may have different goals in the situation than the sender does. The sender wants to talk about getting a COVID vaccine. The receiver may be stressed about why they are in jail and how to solve that problem for themselves. And so COVID may not be the primary thing on their mind at that time. They also may have pre-existing attitudes and beliefs about COVID, which may get in the way of them understanding and receiving communication. We'll talk about those in a minute. And there also may be noise on both sides. There's psychological stress on both sides. There may be distrust, particularly from the detainee to someone who might be part of the jail staff. And there may be ambient sound. My understanding is that jails tend to be noisy places, and that may create a lot of noise in the environment for this conversation to take place. Next slide, please. So let's talk about the source. In the research in health communication, what we have found is that the credibility of the source is really important in being able to communicate an effective message that will be persuasive about health. Now, we talk about credibility as having two dimensions. These are trustworthiness and expertise. So you want to make sure that whoever is presenting this message to the detainee is somebody who is perceived as trustworthy, and also has a lot of knowledge. And again, we'll come back to this in a little bit too. Next slide, please. So the message then is what is being communicated. In health communication, one of the go-to message strategies often is to use fear appeals to communicate. And fear appeal messages are designed to motivate behavior change through fear, activating people's fear. Research shows that these can be effective. But my research and other research also shows that too much research, too, too much fear can overwhelm the recipient. And if they become overwhelmed, they just can't even think about what you're trying to tell them, and they can't process the message. And so you don't want to engage in too much fear. And one of the caveats also is that fear appeal messages are not effective with individuals who are highly anxious. And when we think about then that jail context and the person being there maybe have aroused anxiety because of being in that context, all of these things to me say that maybe fear appeals would not be the right strategy to use in this context. In contrast, I would say that a hope and care message, which may invoke positive emotions and motivation to protect others, might be a better strategy to go. So giving people thoughts about keeping the family safe. Narratives are another great strategy that can go hand in hand with the hope and care messages. And narratives are simply telling stories. And so telling stories of people who have gone through the situation, have had a COVID vaccine, and have done well can be really effective. The other thing that narratives do is help the recipient to get a sense of self-efficacy. Oh, that person was able to do this, so I can too. And that's another important part of behavior change. Next slide, please. The channel is important as well. And whether you do it face-to-face or through some kind of media, they both have advantages and disadvantages. And so the advantages are that in a face-to-face situation, you can customize your message based on the feedback you're getting. If somebody seems confused, you can clarify. The disadvantages are that face-to-face communications then are time-consuming. And it could be that there are implicit biases that may get in the way of clear communication. Media messages have the advantages of being standardized. Everybody's getting the same message. They can be easy and fast to disseminate once you've created them. You just give them out to people on iPads or possibly even through the jail PA system. The disadvantages are that you get no feedback, and so you don't know whether they're being received well. They are impersonal, so people may not think that it applies to them, and they can be easy to ignore. Next slide, please. The recipient is also very important to consider here, and the phrase we think about is to know your audience. In this case, we want to meet your recipients where they are and acknowledge that they're in this jail context, they're stressed by that, and so forth. And so I think in the context of communicating about COVID vaccination in the jail, just acknowledging that this is the context is important. I think also acknowledging the kinds of beliefs that they may bring with them into this conversation can help you to know how to counter some of these beliefs as you get into the conversation. And so in my research, I found that there are racial disparities in beliefs about COVID vaccine. In particular, the Black recipients who were resistant to the vaccine listed ideas surrounding trust and efficacy. So they didn't trust the medical establishment, they didn't trust the jail context, and they also weren't certain that the vaccine was going to be effective. White recipients in my research, in contrast, were more likely to be hanging on to some of these beliefs related to conspiracy theories that the vaccine included this nanochip, or that the vaccine included poisons and those kinds of things. Knowing what those beliefs are can help you to counter them before they even are thought about by the recipient. Next slide, please. And so putting it all together, how would I take all of this information to try to make recommendations for talking about COVID-19 vaccination in the jail? I would say that it would be very good to have an external source that ideally is demographically similar to the population in the jail. I think the external source is important, that it's not perceived to be part of the jail staff because of that trustworthiness concern. And then the demographically similar also helps with that trust. If you can't find somebody who's demographically similar, I think somebody who is highly knowledgeable about medical issues would be useful to at least tag that expertise dimension. I think presenting a message of hope and care, presenting stories about how other people have managed in this context and other people who have successfully been vaccinated and are healthy and their families are healthy, I think that's a really good way to go, and emphasizing keeping them and their families healthy would be the best type of message to present. I think presenting the messages face to face would be great. We're talking about doing some kind of peer education process where it's a face to face conversation, and then possibly augmenting it. You can bring in videos that you might present to the detainees on iPads or something to augment that, which helps to take advantage of the good and the bad of both types of communication. And then understanding the detainees' concerns, so matching the message to their beliefs. One of the things that I have found in my research is that the people who were the least likely to get a COVID vaccine had no thoughts about what the benefits were, the advantages of getting the vaccine. It's often easier to add thoughts than to change thoughts when we're talking about persuasion. So giving them information about why the COVID vaccine is such a good idea, I think is probably the best place to start. So that's all I have for you. Thank you so much. And I'll be happy to take questions.
Thank you so much, Nancy. And again, questions can be directed to the Q&A chat box. We'll move forward with Bianca Birch's presentation titled Culturally Responsive Education and Communication for Vulnerable Populations. Thank you so much. Take it away, Bianca.
Thanks, Tyler. So I'm going to talk a little bit today about culture and communication as it relates to vulnerable populations. So as we process and learn to adopt new ways of thinking about culture and how that plays into our everyday lives, cultural responsiveness is a newer approach to many that is being more widely discussed. Cultural responsiveness involves continuous learning, self exploration, and reflection, and it draws on a number of concepts, including cultural awareness, cultural sensitivity, cultural safety, and cultural competence. So it means being open to new ideas that may conflict with the ideas, beliefs, and values of your own culture, and then brings us into a space that allows us to see these differences as equal and work at decreasing biases and stigmas. So the National Institute of Health has shared information on the importance of cultural respect and acknowledges that when there's a lack of cultural responsiveness, uh, health outcomes are much poorer among more vulnerable groups. And then improving cultural responsiveness can not only remove barriers to accessing healthcare, but may also reduce inequitable health outcomes for marginalized and vulnerable populations, such as those within the criminal justice system. Culturally, responsiveness is also collaborative, it's intersectional, and it's an inclusive approach to care and education. It focuses on promoting self-awareness and practice-based learning for all individuals working in areas that promote a service to more vulnerable populations. Next slide, please. So I'm going to talk a little bit about three different key elements. And so I just want to unpack this a little bit more. I like to look at this as three key elements in helping to define more about cultural responsiveness. So first, I'm going to start with culture. It's oftentimes defined by group membership, such as race, ethnicity, religion, geographic groups, and more that collectively form a set of values, beliefs, customs, and communication that are specific just to that group. And when we think about factors like communication, members of a group learn and facilitate a certain type of communication that becomes a custom within their own group. So, for those who are outside of that group, this could create a barrier or a misunderstanding due to the lack of knowledge or education of that specific group. So, a little bit about cultural competency. This is the ability of for cross culture, and this is bringing together individuals that belong or have a membership in other groups that carry a certain set of values, beliefs, and customs. It's having the ability to conduct self awareness and self assessment, learn to value diversity, and having the ability to manage differences, acquire cultural knowledge, and then being able to adapt to diversity. This is a gradual process that does evolve over time as groups and individuals work to increase their level of understanding and awareness along the cultural competence continuum. And then there's cultural humility, which is a little different as it's more about self reflection in order to be in a space where you can build trustworthy relationships with others that aren't a part of your group. This is a lifelong learning journey, as I like to refer to it. And you start to not only learn about other cultures, but also self reflect on your cultural identity and beliefs. And part of cultural humility is being able to take a step back and look at your own assumptions and values and biases. Overall, the main purpose of this is for people to be more self aware in order to be in a space that allows them to increase understanding of others. Next slide, please. So, as an example of what I mean by cultural responsiveness in communication, is the ability to change perspective or insight of another culture. So, this is a graph that depicts a mixed methods evaluation that was done in 2016, which looked at domestic violence emergencies and deaf and hard of hearing population. So evaluators came in and looked at how effective this training that was offered to law enforcement who were responding specifically to domestic violence calls and those who were deaf and hard of hearing population. So this was a 2-hour training. The evaluators came in and assessed the efficacy. Participants were asked to complete a pre and post questionnaire to assess 4 different areas here. And then the first was satisfaction with the training. Second was to look at skills in responding to deaf and hard of hearing individuals that were in domestic violence emergencies. And then the third was looking at attitudes towards the deaf and hard of hearing, and then which included bias recognition, self-assessment of cultural competency, and perceived self-efficacy. And then finally looking at the knowledge of communication. And because this was a mixed methods evaluation, it also included focus groups. So there were significant differences between the pre and the post questionnaire for for many of these targeted areas, including knowledge and perceived self-efficacy. So both survey and focus groups results demonstrated that participants gained cultural competency skills as indicated by changes in attitudes towards the deaf and hard of hearing individuals, both in a domestic violence emergency and in large scale emergencies. Next slide, please. So I'm going to talk a little bit about importance of messages. So mitigating stigmas and biases in criminal and legal institutions and elsewhere helps to eradicate health disparities by helping to ensure that justice-involved individuals and other marginalized community members feel comfortable and safe utilizing resources while also providing a larger, more equitable safety net that can be sustained beyond the current crisis. So knowing and sharing accurate facts about COVID-19 and the vaccine can help to minimize biases and stigmas. So how does all of this tie into messaging that should be thoughtful and mindful when communicating with individuals from other groups? Culturally appropriate messaging helps to increase successful outcomes, close the disparity and inequity gap, and also yields success with diverse populations. So there are some different types of cultural messaging. And the American Psychological Association has suggested some of the following in efforts to work against biases and stigmatization. One is to amplify the voices of people with lived experiences, specifically with the coronavirus. So while we understand that more people are getting the COVID-19 vaccine and have done well after receiving it, there is still that sense of fear and concern. And having some reassurance from others who are part of that same group that have been vaccinated from the virus can be pivotal in reducing anxiety. And these individuals also have a voice and should be heard as they can be effective in honoring not only frontline workers, but health in general, and then science that is there to help and thereby reducing stigma. And then there's portraying different ethnic groups in public information materials. So visual materials can help change attitudes and or responses. And sharing images that are representative of diverse populations and communities separately and depictions of them working together can help to reduce risk. This can be a powerful communication strategy that promotes solidarity and shared commitment to the overall health and well-being of all individuals. And then there's correcting myths and rumors and stereotypes and challenging those whose language promotes bias. So as a duty to what we do personally and professionally. We all should hold a sense of accountability to correct or decorrect or recorrect, redirect language that is stigmatizing. We should also challenge myths that are out there as they can be harmful and misleading. And everyone, including leaders and community members or members of different groups, should remember to be mindful to not link things like epidemics and pandemics to any particular group. And when that language is put out there, like rumors, they should be challenged to help ensure safety and well-being of those who are part of that vulnerable group. Some of the biggest public health threats are bias, stigma, and discrimination, and they can be damaging. And when other crises arise, it can make it harder to contain. So we should practice good behaviors when it comes to embracing and valuing diverse people and populations. And then there's the spreading the facts. So when there's a lack of accurate or correct information that's shared, that can lead to biases and stereotypes that ultimately can be harmful or vulnerable for vulnerable populations and communities, especially within jail settings. So having culturally appropriate communication that is clear and concise and that is offered in multiple languages can be a key factor reaching people in more marginalized communities and further decreasing those gaps and disparities that affect many. And then finally, and probably one of my favorites here, is engaging social influencers. So bringing in community champions can be very effective in reaching people from other groups. They are helpful in modeling appropriate communication and decreasing fears of scary things like epidemic and pandemic that can be connected to specific geographic areas and or populations. The positive interactions and presence of these community champions can bring a sense of ease here. Next slide, please. So just to help round this out and as part of my closing, I just wanted to share this graph as a way to display how all parties have skin in the game. As the spread of COVID-19 continues, and with the increased rollout of the vaccine, minimizing social and or racial stigmas and biases is imperative, both interpersonally and on a institutional or systems level. For example, uh, interpersonal stigmas and biases may include discrimination towards an individual of a specific demographic, someone of Asian descent, who is assumed to have a particular illness like COVID-19 that is due to socially constructed stereotypes and misinformation. On an institutional or systems level, the COVID-19 crisis can be particularly harmful to marginalized communities due to vulnerability and feeling the need to hide symptoms or have increased mistrust of the vaccine as a way to avoid discrimination, which in turn could put people at an increased risk. And lastly, just recognizing that stigmatized groups are more likely to be or underinsured. So this is just a reminder that we all play a role and that there's power in our voices and in our abilities to connect. And just as importantly, our ability to be effective communicators. And that is all I have.
Thank you so much, Bianca. I really appreciated that graph at the end that showed how to mitigate those unconscious biases at the individual, organizational, and both of those levels. Moving on, we now have a presentation by Parsa Irfani, an MD candidate, as well as Dr. Warso, who has been our in-house COVID-19 expert throughout this journey. She comes from Tufts School of Medicine, but is also an infectious disease liaison for the Massachusetts Sheriff Association. Their presentation is titled COVID-19 Vaccine Education in Carceral Settings, and they'll talk about this interdisciplinary model. Thank you.
Thanks so much for having us, Tyler. We're really excited to be here today We're here to talk about a COVID-19 vaccine education model that we've implemented inside jails. And we'll actually be building off of a lot of what Nancy and Bianca have talked so far about communication. And we've attempted a lot of the things they've shared. We think we've been successful in some and maybe less successful in others. And we hope to kind of share ways we want to improve moving forward in these implementation of education sessions. Next slide, please. So what were these sessions? We called them Ask Me Anything About the COVID-19 Vaccine. They were sessions that were designed for people inside Massachusetts County jails. Anyone who was in that facility could be part of it. They range from about 6 people to about 50 people. They were often 1-hour sessions that were led by physicians, community faith leaders, and medical students. Usually we had about 2 people running each session. The first 45 minutes were a Q&A session for the whole group. And the last 15 minutes was an opportunity for people to come up and ask questions more privately. We held the majority of these sessions in housing units of folks, so meeting them where they're at face-to-face, in person. And sometimes we were doing them more in communal facilities, parts of the facility, such as the cafeteria. And the reason why we decided to do this is because early data in Massachusetts, which is one of the first states that started implementing the COVID vaccine inside jails, is that we saw that the uptake started to be quite low. There was vaccine misinformation as there existed in the community, and we expected there might be barriers to actually getting the vaccine. So we were hoping to be preemptive and proactive in trying to provide education for folks. Next slide, please. We had 4 primary objectives. Firstly, we wanted to provide accessible, updated information regarding the development, efficacy, and side effect profile of these vaccines. Secondly, we wanted to foster an open and non-judgmental space for individuals to share their questions about the vaccine. We wanted to empower folks to make informed, voluntary decisions regarding COVID-19 vaccination. Keyword of voluntary, that was something that we really wanted to emphasize, that we were there to help people make the right decision for their bodies. But embedded in that, we were also upfront that, as people, medical providers, and people who believe in this vaccine, we hope that you take it, and we're here to try to increase the chances of you taking it. So we wanted to increase vaccine uptake inside jails. Next slide, please. So sharing some preliminary data with you guys, we've done these sessions in 7 different jails, which are 9 different sessions. Each session is about 3-hour blocks. We're able to hit usually 6 different housing units in each block. And we looked at the 2 days immediately after each session to see how many vaccine requests were made. And the median number of vaccine requests was 22 after each education session inside the jail. The day of the session, so before the session actually started, the percent uptake inside the facility, the median was 34%. And 2 weeks after the session, the percent vaccinated inside the facilities was 55.5%. The percent increase here, we can't attribute to the program that we've developed, but we think it might have contributed. It could also be related to factors of people in the community getting vaccinated, people's loved ones getting vaccinated, which may have shifted thoughts and attitudes towards the vaccine. Next slide, please. Perfect, thank you. So we wanted to share, the topics that actually people wanted to talk about. I think that's kind of a little bit about what Nancy covered, is really trying to get what people are thinking about. And we had questions that were very general to the community, things around vaccine efficacy, the long-term side effects, the short-term side effects, the effects of variants, government and pharmaceutical distrust. But there were also questions that were really specific to the lived experiences of people who were incarcerated. So one common one was concerns around state-sanctioned medical experimentation on incarcerated people, and if this was another mimic of historical abuses. That was especially the case in Massachusetts because people were being offered the vaccine before folks in the community sometimes were, or their family members were. So that question of am I being experimented on was well and alive. We were talking to folks, many of whom already had COVID. So sometimes the entire room had already had COVID. So the question of, we've already had this, what's the point of this vaccine? I have my antibodies. That was a very common one we got that was unique to the population. And then lastly, and I think really importantly, the concern around how is this going to affect my release process, my vaccination? Because I'm hearing about people being released because of COVID risk. And by getting vaccinated, am I going to have my chances of getting released because of my COVID risk to be reduced, which is a real concern that people grapple with. Next slide, please. So we were hoping to share some lessons learned with everyone, and hopefully in the Q&A we can make this a discussion and hear about what you guys think. But after the sessions, we either had folks sign up on a sign-up sheet, like literally a piece of paper that was there at the end of the session. And in some places, there were 6 slips. 6 slips sometimes need to be requested and then handed in. Often, we didn't have that much leeway in terms of how this was done. It was dependent on the jail leadership and how they were executing it. But on average, we found that when we did have a sign-up sheet, it looked like more people actually signed up. Rather having it right at that moment, rather than having them go back, think about it, request a 6th slip, maybe the 6th slip doesn't come until the next day. All these different kind of barriers that might be in front of people were lifted with this education session, in terms of signing up, at least with this different model. We also found that having the sessions in the housing units were much more impactful than having them in, for example, the cafeteria. And the reason why that is, the cafeteria sessions, sometimes like 6 or 10 people would show up. They would have to move from their housing unit and travel. And maybe like when we started in the housing units, there were 6 to 10 people who were first there. But as they heard the conversation, they heard the questions, people started joining. And suddenly we were groups of 40 and 50. So that was a really important factor that we tried to push towards the end of our sessions to make sure that we're doing these in housing units. We found that asking people what your questions are sometimes didn't help because asking a question can be intimidating. So, asking folks to share what are they thinking about, what's on their mind about the vaccine, and having them just share their opinion was a powerful tactic to just get people talking and opening questions slowly. We also found it helpful to encourage people to advocate for themselves. Obviously, every jail has had a different mechanism of rolling out the vaccine, but sometimes we had folks asking questions like, oh, can I still get the vaccine? Is that still available to me? So really telling people that they are eligible, people have advocated for them to have access to this vaccine, and asking them to advocate for themselves, we also found to be integral. Next slide, please. We really feel like the sessions benefited for having a diversity of voices. So having the medical professional being able to speak from the science side, working in the hospital, talking about taking care of COVID patients, I think was really powerful, but was incomplete. Having trusted community members such as pastors join us and talk about why they're supporting the vaccine and why they think it would be instrumental to the community if people were vaccinated brought a really different but equally, if not even more powerful voice. So I think any sessions in the future around this really should engage different community members. I forget if Nancy or Bianca mentioned having people who look like you talk to you. We found it really helpful to recruit Black, Indigenous, Latinx, people of color to lead these sessions. One of my colleagues who was co-running these sessions with me, Spanish speaking, and she was able to recruit folks from her communities to come and join, and at least in the medical world. And we found that to be really powerful to have people actually speaking in the same tongue as people asking questions. we found that addressing the history of racism and abuse by the medical establishment explicitly, it was really helpful. Sometimes people feel awkward bringing it up. They don't know how it will be received by the presenter. But opening that door, giving people the space to talk about it and doing it with humility, we found to be really essential. And then lastly, around the point of having Spanish speakers, we actually found, mentioning the introduction in Spanish in the education session sometimes didn't cut it. We had to constantly remind people throughout the session that they could ask questions in Spanish. And it sometimes wasn't until the second or the third time when we told people they could ask in Spanish, in which people started speaking in Spanish and really sharing more confidently about what was on their mind. So with that, I hope we gave an overview of what we've done, the challenges, what we've learned, and hopefully how we can improve moving forward as both our setting and the larger US setting. And looking forward to hearing your questions.
Thank you so much, Parcel. With that being said, that wraps up our presentation part of the event. And now, again, just to remind you all, the Q&A chat box is open, so you can include your questions in there. And myself and Dr. Warso will facilitate dialogue with our presenters and make sure that those questions are answered. And if we do not get to all of the questions you asked during today's event, we'll make sure that we follow up in our follow-up email with the responses to those questions that were missed. So I'd like to start with you, Dr. Rhodes. You highlighted the communication model and how there are senders and receivers of information. Are some people or personnel just by nature better senders of information? And if so, could you elaborate on that?
I mean, certainly there are differences in people's abilities to communicate clearly and to communicate well. And I think it is a skill that people can develop. I think that one of the things that we would do if we were going to train peer educators to go into the jails and talk to people would be to help coach them on some of those communication skills. And part of it is to be sensitive to the nonverbal signals that your receiver is sending you, being attentive to their, furrowed brow or they're shaking their head, any of these cues that can be kind of subtle that they might be giving that they're really not where you want them to be to communicate effectively, can help you to recognize, well, maybe I need to step back and reframe where I'm going with this because I don't think we're getting there. So it's a skill that can be developed, but certainly there are people that are naturally better communicators than others.
Of course, and thank you for bringing attention to the nonverbal cues as well in communication that is often equally important in these scenarios.
Yeah, absolutely.
We also heard you all loud and clear that trusted community members and social influencers are helpful in communicating health-related messages. Bianca, I was wondering if you could provide examples of social influencers that may be able to help in the space like this for the participants on the call. Thank you.
Sure. So thinking about some social influencers, I like to call them champions in the community because they have a voice that people listen to. And so that could be anywhere from the pastor, that could be someone who is actually leading an organization, but that could also be someone that lives in the community that doesn't have an affiliation with any organization per se, but their voice is that loud that people listen and people trust them. So looking to see who those individuals are within that community or that group, I think is key in finding out who those influencers are and who can have the most impact.
Thank you so much.
Parsa, I know, we've been in the jails together, and I was just wondering if you could share a few of the questions or situations that you feel, maybe like one or two that you Nancy or Professor Rhodes was talking about, the power of narrative. And I think even if we're talking about the power of narrative in convincing someone to take a vaccine, there could be power in your narrative of talking about our experience with examples. So Any things you can think about, any things that situations and you want to report on?
Sure, yeah. I think one comes to mind in particular. I don't know. I think I won't forget it for a long time. There was a young man who was in one of the sessions and was really attentive, but was also reading a book during the same time. And at some point, after being kind of quiet the whole time, raised his hand and held up the book and told us that the book was around examples in which the US government had experimented on incarcerated people. And he just told us, he was just, truthfully was like, this is what I'm reading. This is my history. This is where I am right now. This is what's been done to people like me. How can you tell me otherwise? And I think building trust in a 1 hour session is probably impossible, right? Unless you're somehow very good at doing it. But I think the most effective way we found to frame it, and I give this to Dr. White Hammond, or Reverend White Hammond, who was with me, who responded to this individual, talked around that the reason why she was here today was so that doesn't happen again. So people know that they have a choice and that this is their destiny that they get to choose, and no one can force it on them. And I thought that was really powerful. And she always emphasized as well, that people have advocated really hard for you in Massachusetts to get the vaccine right now before other folks because of X, Y, and Z reason. And that's why I'm here to make sure that you know that. So, bringing narratives, I think, or acknowledging people's narratives historically and currently, and building off of that to partner with them and say, this is why I'm here, we found to be really powerful.
I'd like to follow up on that question, Parsa, and I'm wondering if you have any examples or scenarios where you might have encountered someone where English was their second language, and how you all navigated that, or even brought them to the table in that moment.
Yeah. So my partner probably would be better at answering this question. Raquel Sofia Sandoval, she wanted to be here tonight. Unfortunately, she couldn't. But so she very, loudly, maybe more loudly than English, in the beginning would introduce herself and tell people that this is also for Spanish-speaking folks and to ask in Spanish. And I'll share, with her permission, one story around sometimes she would do that and like people would kind of start to trickle into the group. And after a while started speaking in Spanish, and one of them came up to her at the end and was like, hey, yeah, I heard about this. I wasn't going to come, I'm not getting the vaccine. But then I suddenly heard her voice and she heard Spanish, and I just came out and I saw, and then I decided to join because I felt like, okay, someone is speaking to me about this and for me about this. And suddenly he felt like this was more for him than it was 10 minutes ago when someone just told him about this session that these random people are coming to do. So I think that example really like hit it home, I think, for Raquel Sofia and I, in terms of how important it is to have language concordance in order to build trust, acknowledging that, like, of course, like, it's sometimes maybe impossible to have language concordance especially like when you're working with immigrant populations where there's many different languages. But that should be our gold standard, and we should be striving towards it as we develop these models.
I also wanted to add, and I think that's a great story, Parsa. I think that everything I've learned about communication and persuasion is that it doesn't always happen all at once, and it happens slowly and maybe over time. And so I think that person who joined the conversation was certain they weren't going to get vaccinated, but joined the conversation because they heard their own language being spoken, might have heard things in that session that might have got them thinking about maybe vaccine isn't as terrible as they thought. And so maybe then the next time a conversation like that happens, maybe they move a little bit farther and a little bit farther and a little bit farther. And so I think that recognizing that persuasion often is a process and not a single event that occurs is really good. And I think that the kinds of things you're talking about and these kinds of things repeated over time can help to, reinforce the work that's, the little bit of work that happens, and then it goes a little farther and a little farther.
Thank you, Nancy. I actually had a follow-up question for you as well. In the presentation, you highlighted multiple modes of communication that may be used. When face-to-face may be an option for some jails, especially those who are still locked down with just their essential staff, but maybe health educators are more community-facing. Are there different modes of communication that would be more effective than others? For example, I think of print materials compared to videos.
So I think always video is going to be more effective than print. If print's all you've got, it's better than nothing. But a video is always going to give you more cues, more to hang on. You have the visual as well as the audio channel to be thinking about, and you can present information in a way that's delivered by somebody who might look like the detainees and have that demographic similarity. And so I think that's always going to be helpful to have a richer communication channel. But also, I think we've learned that some of these synchronous mediated communication modes can be useful. I spend my day on Zoom these days, and it's not perfect, but we certainly are able to get a lot of work done in this context. And I think that perhaps that's an option, using iPads maybe that have a Skype application or something like that might be a way to build in a little bit of the face-to-face in the context when we can't be actually physically present.
Thank you for that. There are a couple of questions in the chat box, and the two that we have are related. So I'll actually present those to you, Parsa, and maybe Dr. Warsaw, you might chime in as well. Matt Costello says, correction staff have been a barrier to vaccinations, and was wondering if we could speak to that. And then we also have from Diane that correction staff seem to be the largest issue with vaccinations, and their vaccination rates are not even reported, supposedly not even tracked. The infection rate is higher than that for prisoners. Is this a focus or a concern? So Parsa and Dr. Warsaw, can you speak to that, please?
Yeah, for sure. Maybe I'll take the second question and I'll send the first one to Dr. Russell because she might be able to answer it better. But in terms of vaccination rates in correctional officers, I think, I don't know, maybe I haven't seen all the data out there, but I think there is limited data. So I don't know how much I can speak to that. But overall, based on what we were hearing when we were going to the jails and speaking to folks, there was a lot of concern and hesitancy and lack of vaccine uptake around correctional officers as well. And sometimes they engaged in the question and answer, even though the question and answer was for folks who were incarcerated. And then some jails actually asked us to hold separate sessions for correctional officers because of low vaccine uptake. I think we enter a lot of complex ethical questions around whether, people should be forced to be vaccinated when they work in congregate settings. I think that conversation has come up for healthcare workers, for people who work in nursing homes, for correctional officers. I think there's a lot of ethical kind of dilemmas and problems with that. But I think we need to, as a public health community, both inside and outside incarcerated settings, carceral settings, be thinking of how we need to be talking to people and kind of, I think it was Nancy who maybe brought this up around understanding what people's concerns are and then coming with question or answers and questions that'll bring that conversation alive. So if, for example, for correctional officers, like there were I remember one person asked about if it causes Bell's palsy, where like half of your face kind of falls down, because that's happened to one of the folks in their facility who was a correctional officer. And for example, that was like one thing they were all concerned about. So having that conversation, I think, ended up being important for that group. So, a long answer to a really good question that, it's concerning. There needs to be, I think, better education for people who are correctional officers, because obviously their risk is also transmitted to folks who are in the carceral settings. And maybe I'll send off to Dr. Russell for the first questions around barriers that correctional officers can create.
Yeah, I mean, what great questions. The first thing to say is that early on, I reached out to the largest corrections union in Massachusetts, and they welcomed me and basically invited me to speak to their union and posted it on their Facebook Live page, a question and answer. And I can say the 10 people who were their leaders of this union all got vaccinated as a way to demonstrate that this was important. So when we talk about COs, I think just like each of our states has been experiencing this pandemic very differently. Being in Massachusetts, my understanding is totally different than being in Florida, and when you know, all of our states, honestly, when the pandemic hit, when the vaccines were rolled out, there's so many things. So speaking of, I refrain from talking about corrections officers as a big like one equals everybody category. So that's one thing that I've definitely learned throughout this time. And there are a lot of corrections officers who have got vaccinated. It is my impression, at least in Massachusetts, reportable. I think our rates were somewhere between 50 and 60%, which is probably less than what you would want. Interestingly, if people got the vaccine through their hospital, like the tracking mechanisms were not great. So if someone got it through their doctor or through a vaccination site, and it wasn't the jail that gave it to them. So yes, I think that we forget that often the people that are behind bars and the people that are the corrections officers are coming from the same blocks, the same community. They're not, and I don't mean that as offensive to anyone. I just mean that as actually truly what my experience has been, in that they know each other's families, and there's a long history between people. So to say that if the CO says, you know, this is not for me, that, and sort of says it out loud or something, and a person who's in jail says, well, he's not going to take it, then why would I? Like, that means more potentially to him than me as the outside person coming in. I mean, for so many reasons. So the interconnectivity between the COs and the people who are in jail, especially for people who are in prison, where it's been, you know, how long, years and years, their lives kind of go together. So I think there are barriers that COs can present if they are strongly against vaccination. However, that has not been my experience. That is the outlier. That is the thing that often gets the press. And when there is a CO talking about it openly and saying this is important, this will help us get through, that doesn't make the media because it's not as interesting, as exciting. So, but they do play an incredibly important role in healthcare delivery in jails. They incredibly, and at this point, I can say, you know, we're 4 months into vaccinating, and, you know, if the CO needs to call someone to get vaccinated, but there's other things going on that might not be a priority in the CO's head, and then that vaccination won't happen. So they're incredibly important partners and stakeholders. And we need to, like Parsa was saying, we need to speak to them with targeted messaging. I just can't, the blame, it doesn't work. I have seen it just not work so far. The blame and the fear and the accusations are, you know, in our socio-political environment, there's a lot of emotions around incarceration and racism and jail. And so there's a lot of feelings people have, but the COs are maybe our partners in this. And so I hope we can potentially maybe reframe how we look at that. So long answer. Sorry.
No, thank you. Thank you for that. And I think it really ties into some of what both Bianca and Nancy were speaking to earlier, especially around the self-efficacy piece and making sure that it's not too much fear appeal, whether it's the messaging to the COs or to the population itself, but ultimately making sure that you're including that efficacy so that those individuals feel powered in that moment to even want the vaccination, and those attitudes change throughout that progress as well. We are getting close to our time. Next slide, please, Stacy. I do see that there was a question in the chat box. If we didn't answer that, I'll make sure that the response is sent out during the follow-up email as well. Our next webinar is on May 27th at 1 p.m. Eastern Standard Time. This webinar doesn't have a title yet. However, we do know that the theme will focus around decarceration. So we encourage you all to join that, and we'll have another really great and robust conversation around that mitigation strategy. We're currently in the process of collecting qualitative feedback from a few individuals, whether you've joined us throughout this entire journey or maybe just stopped in for one. We have been contacting some folks who have been asking to be reached out to and are hoping to just gather some feedback around what your priority areas and needs are, especially for the communities that you're serving, so that we can relay that to our partners at the CDC Foundation and beyond. We will be updating the toolkit. We'll have a kickoff event this fall, and we'll make sure that we send a save the date out once that date and time is confirmed. And then lastly, if there are any needs around peer support facilitation, especially between our center and you all, please do not hesitate to reach out to either myself or Brad on our team, and we can direct you to the correct resources if we have them, or help you try to find those resources if we don't. Next slide, please. Here is our contact information. Again, thank you all so much for joining us today. We appreciate it. Enjoy the rest of your weeks.